This meeting is being recorded.
Okay, I've got the recording on. Oh, well done. I got worried. Can you hear us, Matt? I'll just turn this off.
Yeah, no, I can hear you.
Okay. I just wonder where would you put this microphone? I'll leave it where it is. We're going to get a sandwich and then we can start in just a minute. Oh, thank you. Thank you. Right, we're all settled out. Let's check the Zoom app thing. Well, the problem with that microphone, it keeps interrupting really well. All right, are we all set? Yeah. Okay, Matt, I think you can start.
Okay, perfect. All right, I'll get going. Can you see my screen okay? Is it still working?
Yeah, we can. It's all good.
Perfect. Okay, so yeah, this is the title of the paper I'm going to present. So it's hang on. This paper here, which was published in JCM this month. So, well, the title is as it says. So it's a study that is assessing whether the dysglycemia that we, has been well observed during COVID infection might become a potential public health problem after the resolution of the COVID. And it's something that I think probably all of us have thought about or worried about to varying degrees in terms of, is this going to, was the potential for COVID to produce a huge increase in the number of new diagnoses of diabetes. And obviously it's still an emerging kind of phenomenon, is still being studied, but this paper does sort of add a little bit to that, I think, and so that's part of the reason why I've chosen this one. And so this was work done in Italy, in Milan, in an adult cohort early in the first wave of the pandemic, so early 2020. And it's integrating data. It's from a single hospital setting, so looking at fasting blood glucose data, both during admission and then following post discharge follow-up, but also then retrospectively looking at fasting blood glucose data for the same patients where it was available before they were admitted with COVID, and then putting it all together. So the patient cohort was 660 adults in total that were admitted between February and May in 2020 to a hospital in Milan, and so they were classified using the American Diabetes Association criteria as being either having a pre-existing diagnosis of diabetes, of having a new diagnosis of diabetes during their admission, having hypoglycemia but not in the diabetes range, or being normoglycemic throughout. And I'll define all of these later on. And then the fasting blood glucose prior to the admission and during the follow-up were classified either as normal, which is just FBG. So when you see FBG, that's means sort of normal glucose, or impaired fasting glucose, which will be IFG, or fasting glucose in the diabetes range. So for those that were already diabetic, so that's when you see DFG, that's what that means. So yeah, this is just summarizing the abstract, by the way. So I'll go into obviously more detail. So of the 660 patients that were admitted, so this was all the patients admitted to the hospital, 589 of them had a confirmed diagnosis of COVID. And they showed that there was a significant proportion had hyperglycemia. So actually it was 70% in total had abnormal blood glucose, with only 30% being normoglycemic. And those with...
Did they do any HbA1cs at the start?
So I'll show you the HbA1c data later.
Right.
There is some. There's not a huge amount actually, but yeah, I'll come to that. So those patients that had dysglycemia had an increase in increased inflammatory markers of markers of inflammation, and also poorer clinical outcome than those with normoglycemia, and that was actually different between those that were diabetic and those that had hyperglycemia that was not diabetic, and there was sort of three distinct populations, and those that were normoglycemic. But importantly, after the infection resolved, then the prevalence of dysglycemia reverted back to the pre-admission frequency, so where they were comparing the blood glucose data that was available before admission. So the conclusions that the authors of this paper have drawn is that COVID-associated dysglycemia is unlikely, based on their data, to become a lasting public health problem. And I like the phrase that they used here, saying alarmist claims on the diabetes risk after COVID-19 should be interpreted with caution. And I know people have been a bit worried about it. So I will now go into a bit more detail and explain their kind of rationale and exactly what they did. So we all know that individuals with diabetes, we've seen have developed more severe disease when they've had COVID infection. Both type 2s more than type 1s, at least in the experience of people that I've seen, but certainly it's definitely a risk factor for developing more severe disease. And we've definitely seen that acute metabolic decompensation of diabetes, as in hypoglycemia, is a well-recognized complication with a COVID infection. And there have been some cases reported of newly identified or new onset diabetes at the time of COVID infection. And there's been quite a lot of, there's been a lot of work done to see if, or try and assess if the actual SARS-CoV-2 virus has a direct toxicity against the beta cells in the pancreas and having a directly diabetogenic effect. I think there's a lot of work out there already on this, and I think the jury is out somewhat. There's been several proposed mechanisms as to how this might work, and ACE2, which has been bandied around obviously since COVID first emerged, has been implicated because it is around in the beta cells and as a receptor. So that's been proposed, as has this transmembrane serine protease 2 as a kind of effector in a kind of mechanistic pathway. They've been investigated, but there's not a huge or there's not a significant conclusive amount of evidence to suggest that these might be a direct route of COVID virus toxicity to the pancreas. But certainly studies are in agreement that the virus has been detected in pancreatic tissue during acute infections, where and we know that there's pancreatic inflammation occurs in a proportion of people who have severe COVID. And so it might be that this virus mediated inflammation could be indirectly affecting beta cell function. And so, definitely COVID pancreatitis has certainly been a thing in severely ill patients, and that's reflected in the standard things for standard markers of pancreatitis and liver amylase and things. But it's certainly not beyond the possibility that would directly affect beta cell function and render you slightly insulinopenic. But yeah, so the acute pancreatic inflammation in the context of infection doesn't imply, though, that the virus itself or infection with the virus will have a permanent effect on glucose control and trigger a permanent diabetes after the infection is resolved. So there was another recent study from Italy last year in Nature Metabolism, which is this Montifusco paper, that reported that in patients with new hypoglycemia seen during admission for COVID, that hypoglycemia persisted at 6 months, which is the same duration of follow-up that they've done in this study. At 6 months, persisted in 35% of patients. Admittedly, it's quite a small number of patients, but that's a significant proportion. But in counter to this, the authors of this paper, the one I'm talking about now, had a slightly smaller study prior to this one, which showed that something the complete opposite, where they've only had a small percentage, so only 4% of their patients had persistent aberrant glycometabolic, not bulic, typo, during follow-up. So there's a difference between the two here. And so this study tried to kind of add a bit more detail and try and get a bit more information in terms of pre-admission glucoses as well. So they looked at these 660 patients that were admitted with it wasn't all admissions, but given how things were the first wave here, it probably was all admissions to the hospital, but it was all patients admitted with a pneumonia, essentially. And then, so importantly, the dysglycemia here in this paper, they classified using the same criteria as this Montifusco paper, which were actually different to what they used in their first paper. So that's a point that I'm going to sort of cover in the discussion. But to see whether or not this hypoglycemia that you see during admission with acute infection, whether it persisted or whether it reverts back to normal when the viral infection is cleared. So the population that they used was 660 adults admitted to this single center in Milan in early 2020, and they split them into either confirmed COVID-19 or no COVID negative, and their confirmed the criteria for confirmed COVID case was either a positive PCR result and radiological findings consistent with a COVID pneumonia, or if they were negative for PCR, then radiological findings with a positive antibody test against the spike protein. So this is all pre-vaccine. So it's assumed that any positive IgG or IgM at this point would indicate having had an actual infection rather than anything else. And then they were only considered to be COVID negative if they had a negative PCR and they didn't have any detectable anti-spike antibody. So they also did, sort of standard, what we now say sort of standard-ish COVID bloods, plus they did IL-6 levels for all the patients, but they've done the usual inflammatory type markers. So things that we think about for COVID are things like ferritin and LDH and D-dimer and things. And then they measured fasting blood glucose in each patient during hospitalization. So they've got between 3 and 2.5 and 5.5 time points per patient. So the answer is 5.5. These are these are fasting blood glucoses rather than just a random one. And they managed to retrieve fasting blood glucose data in the 12 months prior to admission for 234 of these 660 patients. They also took HbA1c levels during the admission and also where they were available in the year prior as well. And then they saw these, as well, they saw patients as they could in post-discharge follow-up visits at 1, 3, 6, and 12 monthly outpatient visits. Most of the patients were seen around 6 months, but there is a bit of variation. And they were so these are the criteria that they used, which were used in the previous paper. So pre-existing diabetes was if they'd already either had a documented diagnosis of diabetes or were prescribed medication for that. They were defined as a new diagnosis of diabetes if there was no prior history and their fasting blood glucose during admission was greater than 7 or greater. And then they're non-diabetic. So they say hypoglycemia not in diabetes range, but at some points I've written non-diabetic hypoglycemia just because it takes up a bit less space. But that was if the random if they had a random blood glucose between 5.6 and 11, or 2 fasting blood glucose readings in the range of 5.6 to 7. And then normoglycemic if there was no history of diabetes and if they had normal glucose levels. And so, yeah, so the fasting blood glucose was defined in the same way as per ADA criteria, which is normal fasting glucose being less than 5.6, impaired being 5.6 to 6.9, and then diabetes range fasting glucose, which is the DFG that I mentioned, is 7 or higher. And then I won't cover the statistical methods that they use, but they do all seem appropriate, and they do all have appropriate post hoc correction after hearing your mention yesterday, Prof, of not having appropriate Bonferroni and such like. They do seem to have post hoc'd everything properly. So in terms of results, so of these 660 suspected COVID patients, 89% of them were confirmed positive COVID, so 586, leaving about 11% in the non-COVID cohort, so 74. So they all, as I'll mention later, all the analysis they did with the COVID cohort, they also did with the non-COVID, but they, as I said, the 74 patients, it's too small a number to really kind of draw any meaningful conclusions from the non-COVID cohort. So actually most of the results now that I'm going to talk about are just from the COVID cohort. But in general, the cohorts are well matched in terms of the age, BMI, ethnicity, etc. It's all detailed in, if you're interested, in table 1 of the paper, but I haven't put that on because it's just loads of numbers and it's not particularly exciting. So I'll go to the next figure first, but in terms of the HbA1cs, obviously these were higher or significantly higher in the confirmed diabetic patients than the other 2 groups. So mostly we're talking about 3 groups, which are the diabetes, then hyperglycemia, which includes the new diagnoses of diabetes during admission, and then the normal glycemic. So most of the figures are divided into three categories.
So does that mean did everyone have an A1C there on admission? Because that's something we should have done, I think.
So I don't think there's values for quite all of them. It's a little bit difficult to interpret because you'll see when they've charted it, because some of they're talking about follow-up as well, and obviously they didn't manage to follow everybody up. So they definitely didn't have HbA1cs for everyone. Right. Definitely not. I can actually probably, well, when we get to that figure, I can show you the actual numbers, and
okay.
It's not all of them, unfortunately. So in terms of the actual numbers with in the cohorts, so can you see my mouse pointer? It's probably easier.
Yes, yeah, we can.
Right, yeah. So the HbA1c levels are reflected in panel B of figure 1 here, where there is this significantly increased HbA1c in the diabetes patients, which we would expect. And that's also reflected in the peak glycemic values as well here, which again you would expect. So importantly, the numbers of total diabetes, which is how they referred to it, which they've kind of put together the pre-existing diabetics here with the new diagnoses, and they actually kind of work out fairly similarly. And actually, there's more new diagnoses in the non-COVID than there is in the COVID cohort. But again, it's a very small number here. But the important figure is that there's a significant amount more hypoglycemia in the COVID patients than there is in the non-COVID patients, with an appropriate reduction in the amount of normoglycemic patients that there are in the COVID cohort. So there's definitely more abnormal blood glucose. 70% of the COVID patients have abnormally high blood glucose. And then in terms of inflammatory markers, they're raised. All of these patients have been admitted unwell. They are higher in the diabetes, and these are all the COVID patients, I should say, as well. So you would expect them all to be elevated to some degree. Interestingly, IL-6 isn't elevated for any of them, and some of these, a fair proportion of these patients died. Yet they didn't have a significantly high IL-6. But in general, the white cells, the CRP, there is a significantly higher inflammatory markers in those that have diabetes and have high blood glucose than in the normoglycemics, which again is sort of what we would expect and what we've seen anecdotally from treating COVID patients. So this is reflected that with high sugars there is more inflammation in the context of a COVID infection. Now, the clinical outcomes when they talk about it is their composite endpoint is only ITU admission or death, whichever came first, they said. But obviously you're not going to go to ITU after you've died. But so it includes all those that went to ITU and then subsequently died or went to ITU. So, but it's a fairly significant outcome. And there's a strong association between the degree of dysglycemia and the adverse and the risk of adverse clinical outcomes. So, which with diabetes being more significant than the non-diabetic hypoglycemia, again more significant than normoglycemia. So if you see here the Kaplan-Meier curve here, the top line is the normoglycemia, and then there's a significant step down to the hyperglycemic. So this is the non-diabetic hyperglycemia group, and then those with confirmed known diabetes do significantly worse. And again, in terms of this, the hazard ratios, there's not actually in this case a difference between the hyperglycemia and the normoglycemia, or between the hyperglycemia and the diabetes, but between diabetes and the normoglycemia, there is a significant difference here. So definitely having higher sugars is bad in terms of the adverse clinical outcome, and the patients with higher sugar, so those 70% of patients with either hyperglycemia or non-diabetic hyperglycemia or diabetes had longer stays, and these were, so in some cases, quite long admissions. So in terms of what happened to the sugar following discharge, now, so they managed to follow up 75% of the COVID cohort that were discharged. So obviously, there were 586 originally, so 111 patients in the COVID cohort died, so weren't discharged, but they managed to follow up 75% of those. And of the original 586, and actually of the 475, they managed to find 199 fasting blood glucose values from before admission. And so the known diabetics didn't show any change at all to their fasting glucose following admission, and none of them, when they were followed up, required any escalation of treatment. So their diabetes essentially was the same 6 months after COVID as it was before COVID. and actually the only difference that was seen in terms of observable fasting blood glucose was in that hyperglycemic, that non-diabetic hyperglycemic newly diagnosed diabetes group, where there was an increase, a significant increase in fasting blood glucose during the acute infection, during hospitalization. But actually, when it came to 6 months follow-up, that had returned to pre-infection levels, which I can show you now. So if you look at the actual numbers, there are not values. It's not a complete data set in terms of there aren't values for all patients for all time points, but there was a significant increase during admission in fasting blood glucose of these patients with either newly diagnosed diabetes or non-diabetic hypoglycemia, but that did resolve at follow-up. So whatever transient impairment there was in glucose control seems to have resolved when it came to follow-up. Now these are the HbA1c values. So on the right-hand side here. So obviously these three numbers here do not add up to 500 and whatever it was. So they don't have, or they haven't fully, if they do have, they haven't published HbA1c data for every single patient. But I think this may be in the context of they've only here put down the HbA1cs for those that they had ones from beforehand, if that makes sense, because they did talk about finding HbA1cs from before admission. So I think where it says admission, although it's a little bit unclear in the text, admission is pre-admission, and follow-up is basically showing that there's no significant change in HbA1c, even in the diabetics or the newly diagnosed ones. So what they haven't said is how many numbers they have, or how many values they have for HbA1c for those that were admitted, if that makes sense. So I can't answer your question, Prof.
Sure.
It does. Yeah. No. The HbA1c is listed in the table in table 1, where they put all of their results, but they haven't said how many they are missing. Although, oh no, they're missing quite a lot. They're missing like 400. So yeah, they haven't got them for all of them, which I guess is a big problem. But the ones they do have, and I guess it's quite underpowered relatively because there's not that many, but they haven't shown any significant change. And as I said, in the non-COVID and the no-COVID cohort, the numbers were very, very small, but the general were the same, which would be expected because there's no COVID there. So the kind of outcome of this paper is that there is dysglycemia seen during COVID infection, which we knew about, but it resolved in the majority of the patients after the infection resolved. And similar was seen in the non-COVID patients. And so their conclusion is that it's reasonable to speculate that inflammation-induced insulin resistance, just due to acute illness and acute pneumonia, independent of the actual mechanistic cause of the pneumonia, it could be the reason for this. And we know this anyway. We know that people become hyperglycemic when they're septic. So they're saying that it's not unreasonable to assume that this isn't specific to the COVID. It's just the fact that COVID is a significant and severe infection that provokes a severe inflammatory response in patients. And this was supported by the observation that they showed that there was more inflammation with more dysglycemia. So those with higher sugars had more inflammation. And they're saying that their findings don't support this long-term disruption to glucose control that was reported in this previous study. And in this one, they are using the same criteria to define hypoglycemia and impaired fasting glucose as that original paper was. So they are saying it's more directly comparable. And So they're saying that at 6 months of follow-up, there's no significant change in the fasting glucoses or the HbA1c in any of the groups where they've looked at, either the known diabetics or the normal glycemic ones. And so they did have more, there was more hyperglycemia, non-diabetic hyperglycemia in the COVID cohort, but that did resolve, which could be accounted for by inflammation, as that was shown with the blood results. And the mortality was higher in the COVID cohort, so that the mortality in the COVID cohort was 19%, and I think 12% in the non-COVID cohort, which would suggest that the COVID, there were more severe infections in COVID cohort with higher degrees of inflammation, which could account for more dysglycemia. And this, it's a 500-600 patients and showing that dysglycemia has a strong association with an adverse clinical outcome here. So it's definitely an observable, a real effect. And this does support the need to screen all COVID patients for hyperglycemia at the time of admission, irrespective of any history of diabetes, which I'm not sure how it was done everywhere in the UK, but certainly when I was working at both Norfolk Park and at Barnet, we were definitely doing this. So at Barnet, all COVID admissions got an HbA1c, as well as glucose is done as soon as they came in. But certainly it seems like you need to control the sugars. So the dysglycemia, there's a number of different mechanisms that they have said it could be caused by. We've covered a couple of these. So the first one being stress hypoglycemia, because they're just severely unwell or significantly unwell. The second being that they may, these people may just have had unrecognized, undiagnosed type 2 diabetes that has just been diagnosed when they've become unwell. They've just been kind of not quite at the point where they become symptomatic. But the third is the thing that I think everybody wants to know, which is there a direct effect on the pancreas of the SARS-CoV-2 virus, and is it directly diabetogenic? I don't think there's enough evidence for that yet. And the fourth is an important point, which we haven't forgotten about, is it could be dysglycemia secondary to things that we've given to try and treat COVID. So the main one we're thinking of is glucocorticoids. So the important point here, though, is that this was done early in 2020 in the first wave, before actually dexamethasone was being used. This is before data for that, and it was kind of only being used a little bit empirically and kind of word of mouth. People were giving it just because there wasn't anything else to do. So in this study, in the COVID cohort here, only 20% of the patients had or received steroids. So it's less likely that the dexamethasone given here would have played a significant role in that dysglycemia that they're looking at. Whereas obviously if this has been done later on, then in theory anybody needing oxygen would have had steroids. So there are a few limitations with this, which is that obviously this only captures those patients that were significantly unwell and required hospitalization. It doesn't give any information about if there was dysglycemia in people who had milder symptoms and didn't require admission. And obviously they didn't have data for every patient pre and post discharge. They only had, it was retrospective in terms of looking for data from the 12 months before admission. And it only used fasting blood glucose as a measure of glycemic control. They didn't look at actual markers of beta cell function. So they haven't looked at C-peptide levels or insulin levels or any of those things that you would need to do if you were trying to kind of get into a bit more kind of mechanistic kind of detail about these things. This is a predominantly, it's about 85-90% European, Italian and European cohorts. And so you can't assume that these findings apply to all ethnicities, because there could be, significant beta cell functional capacity. So it's limited in that respect. And I think the main one potentially is that 6 months follow-up, as was done here, might be just too short a time to to be able to uncover if there is an effect. I mean, it may be that there's a delay and that the inflammatory damage that's suffered during infection doesn't manifest itself as diabetes for a longer period of time. But we don't know that. No one knows that, and until it happens, or if it does happen, we won't know. Well, certainly. So the main conclusions from this paper were that COVID-associated dysglycemia caused an increase, or was associated with an increased level of inflammatory inflammation, with increased indicators of organ damage, which was implied by the blood results they had, and definitely a poor clinical outcome, which supports these need to screen all COVID-19 patients for hypoglycemia at the time of admission, and if they are hypoglycemic, then to obviously optimize their blood glucose to prevent having a worse outcome. But the data that they've presented in this study don't support the persistence of long-term disruption of glycometabolic control after COVID infection. But as they fully admit that much larger, multi-center, longer-term, epidemiological studies are needed to see if COVID does induce a permanent diabetes, because it may just be that there's not been enough time yet. But yeah, I think certainly it's, and these just the two papers that I mentioned, the previous one and the one that this team had previously done. But the reason I picked it is because it is, I think, something that we've worried about and are still probably worrying about to a certain degree, in terms of if it does turn out that COVID causes diabetes, then we may well have an explosion of cases in the coming years, and it's what we do about it. But potentially it all settles down. But yeah.
Okay, thank you very much. Any other questions or thoughts? I'm surprised they didn't do HbA1cs at the start and use it as a definition for diabetes, because they kind of use it as an outcome and then it didn't do any. Because as you said.
Yes. Yeah. No. They're definitely using the fasting blood glucose as their definition of diabetes rather than A1C.
Good. Thank you. Any other thoughts, questions? No, everyone's very quiet here. Anybody on that? Okay. No. Okay. Great. Thank you very much. Ooh, yeah.
Okay. No problem.
Okay.
Yeah. Okay.
Thanks very much. Bye.
All right. No problem. Bye.